Bronchiectasis. That's a word you've probably heard before. But what does it really mean? In this sketch, we'll dive into the causes, clinical presentation, diagnosis, and management of bronchiectasis to help you look like a rock star on the wards. Bronchiectasis is a condition characterized by chronic airway inflammation, dilated and easily collapsible airways, mucus plugging, and impaired secretion clearance. Our recurring sketchy symbol for bronchiectasis is a big, red, dilated pomegranate, which is why we're here in Pomegranate Grove. The pathologic process underlying bronchiectasis is an infectious insult made worse by impaired drainage, airway obstruction, or a weakened immune system. The body can't fully clear the infection, leading to inflammation, destruction, and neovascularization of the airways. This remodeling is irreversible and results in progressively more dilated and tortuous bronchi, which further impairs clearance of secretions. Uncleared pulmonary secretions are a setup for infection, leading to a vicious cycle of recurrent infection, inflammation, and remodeling that defines the condition. We'll be focusing on the clinical presentation of bronchiectasis from here on out. If you're interested in an in-depth discussion of the pathophysiology, check out our asthma and bronchiectasis sketchy path sketch. Let's fill out our SOAP note with what you'll see in a classic bronchiectasis patient. Bronchiectasis most commonly presents with complaints of chronic cough with daily production of tons of purulent sputum. In fact, the classic description is that patients cough up cupfuls of the nasty green stuff, just like that nasty pomegranate dripping with green gunk. The combination of chronic pulmonary infections and the inability to clear the resulting secretions leads to the accumulation of those secretions in the bronchiectatic airways. As you might imagine, all this junk in the bronchs can make breathing kinda tough. It may also make coughed up sputum blood-tinged from airway bleeding. Let's go over some of the high-yield questions to ask that can clue you into a diagnosis of bronchiectasis. First of all, a young patient presenting with the classic symptoms of bronchiectasis should raise red flags for cystic fibrosis. That's because CF is the most common cause of bronchiectasis in the U.S. Thus, if you know your patient has CF, you can assume they already have bronchiectasis. At Sketchy, our recurring symbol for cystic fibrosis is that thick, yucky tree sap, running all over that tree branch. Other clues to lead you to CF as the cause of bronchiectasis include symptoms of GI malabsorption, such as steatorrhea and malnutrition. For an in-depth discussion of CF, stay tuned for Sketchy Peds. Ask your patient about a history of frequent sinopulmonary infections, which may suggest an underlying immunodeficiency or airway obstruction, both of which can cause bronchiectasis. Of course, one chronic, never-ending pulmonary infection can also lead to the same persistent airway inflammation and irreversible bronchial wall destruction that defines bronchiectasis. Exotic lung infections to ask your patient about include tuberculosis, represented by those cacti filled with cavitations, Mycobacterium avium complex, symbolized by the Mack mockingbird, and aspergillosis, symbolized by the scarecrow. Each of these diseases has its own set of red flags, such as night sweats in TB and untreatable asthma in allergic bronchopulmonary aspergillosis. Check out our pneumonia and special population sketch for more details on these and other exotic pulmonary infections. Patients with bronchiectasis can develop exacerbations characterized by worsening cough, sputum production, dyspnea, and pleuritic chest pain. At Sketchy, our recurring symbol for any exacerbation of the disease is the flare gun. Exacerbations, especially before the diagnosis of bronchiectasis is made, are often misdiagnosed as bronchitis and require therapy with repeated courses of antibiotics. If this sounds like your patient, they might have bronchiectasis. We'll talk about management of bronchiectasis exacerbations in a moment. For now, let's move on to the objective findings of bronchiectasis, starting with the physical exam. Clearly, the lung exam is paramount. Patients with bronchiectasis will classically have crackles and wheezes on auscultation. Check out that lookout in the tower, with his super 80s Velcro jacket flapping in the wind, blowing that wheezy party blower. Not the stealthiest of lookouts, that guy. Beyond the physical exam, the diagnostic tests we order when we suspect bronchiectasis serve to confirm the diagnosis and identify potentially treatable causes. The chest X-ray is junky and abnormal in most patients with bronchiectasis. However, no one finding is diagnostic of the disease. Features that suggest bronchiectasis on chest X-ray include dilated and thickened airways that show up as parallel lines, aka tram tracking, kind of like the sides of that ladder, or white donuts, aka peribronchial cuffing, kind of like that kid's super white shirt cuffs, as well as irregular peripheral opacities that represent mucopurulent plugs. Even better, high-resolution chest CT is the diagnostic test of choice for bronchiectasis. If the chest X-ray is abnormal and you suspect bronchiectasis, order a chest CT. Our recurring sketchy symbol for CT is the black cat. And it's wearing that gold collar since it's the gold standard. The classic CT findings of bronchiectasis are abnormally dilated and thickened airways. Bronchial wall thickening will also be evident. As you move toward the periphery of the lungs, the airways will not taper down like they should. Airways, as you'd expect, will also be filled with secretions and debris. Pulmonary function testing is used to assess the functional respiratory impact of bronchiectasis. On spirometry, an obstructive airflow pattern is most commonly seen, with low FEV1 and an FEV to FVC ratio of less than 0.7. Oops. That leaf blower, which looks awfully like a spirometer, doesn't seem to be working. Guess that obstructive-looking pile of leaves isn't going anywhere. For more info on obstructive and restrictive spirometry patterns, check out our PFT's how-to sketch. Once you suspect bronchiectasis and have confirmatory imaging findings, the next step is to figure out the underlying cause. Bronchiectasis is the end result of chronic airway infection and inflammation, which can be precipitated by a lot of different conditions. Identifying the underlying cause is important because it guides therapy. We'll go over a bunch of labs that are often ordered when bronchiectasis is suspected. Remember, the tests you order for your patient should be guided by the history and the findings you've already obtained. In young patients with dyspnea, purulent sputum, recurrent pulmonary infections, and upper lobe predominant bronchiectasis on CT, consider cystic fibrosis. Patients are often super thin due to malabsorption caused by pancreatic insufficiency. If you do suspect CF, well, it's time to get them all sweaty. Just like that helper kid. Order sweat chloride testing to confirm the diagnosis of CF. Patients with recurrent sinopulmonary infections, but without other features of cystic fibrosis, may have an underlying immunodeficiency predisposing them to recurrent infections. If this is your patient, order a quantitative immunoglobulin analysis to measure their levels of IgG, IgA, and IgM. If you suspect a chronic exotic pulmonary infection such as TB or MAC, get sputum cultures to confirm the diagnosis. See that scarecrow standing guard there? That's our recurring sketchy symbol for aspergillus, which is a bit of a special case, since it presents with a unique history. In patients with hard-to-control asthma and central bronchiectasis, test for allergic bronchopulmonary aspergillosis by checking aspergillus-specific antibodies and total serum IgE levels. Just remember those antibody-shaped scarecrow hands holding an extra-long IgE pitchfork. These levels will both be abnormally elevated in a patient with ABPA. So you think it's bronchiectasis, eh? Before you boldly make that statement in front of your attending, let's take a look at some of the other conditions that should be on your differential for a patient presenting with chronic cough. Some of the most common causes of chronic cough include upper airway cough syndrome, chronic sinusitis, and GERD. You should definitely think about these conditions first, simply because of how frequently they occur. Fortunately, these conditions typically don't present with copious sputum production, a unique identifying feature of bronchiectasis. One disease in particular to pay attention to is asthma, which can also cause chronic cough. Since asthma and bronchiectasis are both obstructive lung diseases, simple spirometry testing won't be sufficient. However, spirometry testing pre- and post-bronchodilator administration will distinguish asthma, which is characterized by reversible lung obstruction, from bronchiectasis. If your patient is a smoker and presents with a chronic cough, COPD and lung cancer should be high up on your differential. In these cases, chest imaging, especially chest CT, will help distinguish bronchiectasis from these other diseases. All right, let's summarize the typical bronchiectasis presentation in a sample assessment. Jane Doe is a 23-year-old female presenting with shortness of breath and a 2-year history of daily cough and significant purulent sputum production. She has a history of recurrent sinus infections and chronic diarrhea. Pulmonary auscultation is notable for scattered inspiratory crackles and wheezes. Chest X-ray shows dilated airways and irregular peripheral opacities. Overall, I suspect that the patient has bronchiectasis, possibly due to cystic fibrosis. Congratulations! You've diagnosed your first case of bronchiectasis. Now what? Unfortunately, of the broad spectrum of causes of bronchiectasis, only a few respond to direct treatment. For those cases, the priority is reversing the underlying cause and preventing further damage. For example, patients with exotic infections like TB or MAC can be treated with special antibiotic regimens, while those with certain primary immunodeficiencies can receive IV immunoglobulin to bolster their immune system. For more details on the management of these specific diseases, check out their respective sketches. As we mentioned earlier, the airway changes in bronchiectasis are irreversible. Therefore, for the majority of patients, treatment focuses on infection control, inflammation reduction, and bronchial hygiene to minimize further injury. Speaking of infection control, let's talk about management of bronchiectasis exacerbations. A common occurrence in patients with bronchiectasis, exacerbations are characterized by a worsening of those classic bronchiectasis symptoms. And as you might have guessed, antibiotics are the keys to treatment. Broad-spectrum antibiotics are generally preferred since patients with bronchiectasis are typically colonized with resistant bacteria such as Pseudomonas. At Sketchy, our recurring symbol for antibiotics is the ABX pill bottle. Check out our pneumonia in special population sketch for more details on how to treat Pseudomonas. For patients who have or are at high risk for frequent exacerbations, prophylactic antibiotics can help reduce the frequency of exacerbations and fight the progression of bronchiectasis. Once again, these antibiotics should be broad-spectrum and given in oral or inhaled forms. Bronchial hygiene is critically important to keeping bronchiectasis patients out of the hospital. The goal is to keep the airways as clear as possible to minimize mucus plugging and bronchial obstruction. Bronchial hygiene includes hydration, chest physiotherapy, aka beating on the chest to break up those secretions, just like this kid here. Inhaled bronchodilators to widen those airways, and inhaled mucolytics, such as hypertonic saline or DNase, to loosen up airway secretions. If bronchiectasis is really bad and medications aren't enough, surgery, symbolized by that scalpel on Chest Boy's belt, is your last line of defense. Surgical resection can be helpful for severe disease localized to a single lobe, whereas patients with widespread end-stage bronchiectasis, such as in CF, may ultimately require lung transplantation. Okay. Let's finish up with a brief recap. The classic presenting symptom of bronchiectasis is a chronic cough productive of cupfuls of purulent sputum. Since bronchiectasis is an end result and not a disease in itself, be on the lookout for symptoms and signs of the conditions that commonly cause it, such as cystic fibrosis, immunodeficiency, and exotic pulmonary infections. If you suspect bronchiectasis, a high-resolution chest CT is the diagnostic test of choice and will show abnormally dilated and thickened airways filled with secretions and debris. To treat your patient, focus on reversing the underlying cause of bronchiectasis, if possible. Otherwise, management revolves around antibiotics and bronchial hygiene, like chest PT, bronchodilators, and mucolytics, to treat and prevent bronchiectasis exacerbations. That's all for now. Come back next time to learn about another pulmonary shunt process.